Hello, everyone, and welcome to today's online event presented by the National Newcomer Navigation Network, which is funded by Immigration, Refugee and Citizenship Canada and is hosted by the Children's Hospital of Eastern Ontario. N4 recognizes and values the continued connections and our ongoing relationships with our Indigenous peoples in Canada, the traditional stewards of this great land, which has become the home to a diverse population of other peoples. CHEO and N4 are housed on the traditional and unceded territory of the Algonquin Nation, and for that, we are thankful. My name is Natalie Graham, and I'm the Learning Specialist for N4, and I'll be hosting today's event. Mariah Maddock is my co-host for today and will be facilitating the question and answer discussion board. I am pleased to introduce you to our speaker for today's N4 webinar entitled, Considering Cultural Safety in Working Across Cultures. Marie Serdynska is the coordinator of the Montreal Children's Hospital Sociocultural Consultation and Interpretation Services. She is responsible for equity and social inclusion education and interpreter recruitment and training. She was co-chair of the Canadian Consortium for Health Equity and of the first National Transcultural Health Conference. After obtaining her Bachelor of Social Work with great distinction from McGill University, Marie joined Head and Hands as a youth counselor, educator, and group facilitator exploring youth issues through theater. With the YWCA, Marie counseled and hosted cross-cultural parenting groups for young families using creative forms such as dance, theater, and poetry to demonstrate social issues. In addition, she coordinated an international development education initiative identifying global issues in health, literacy, food security, and strategies for unlearning racism. She also collaborated in developing intercultural staff training and the first multicultural policies for the YWCA. With the Montreal Consortium for Human Rights Advocacy Training, working with an advisory committee, she produced with others a human rights manual for youth, which was distributed to schools and later used for training. As a reminder, today's session will be recorded and will be uploaded to our N4 website within 24 to 48 hours following today's presentation. Should there be any technical issues during this webinar, all attendees will be informed with details on an alternate session. And before beginning today's event, I would like to introduce you to our platform features that help enhance your participation experience. So throughout today's session, we invite you to enter your questions in the Q&A window. These questions will be answered in the question and answer session following the presentation, and we'll be monitoring these questions throughout the session. You can view the questions being asked and click on the thumbs up button to upvote the question. You can also use the comment feature to make a comment or add to a question being asked. And Mariah may answer some questions during the session while others will be saved for the live question and answer session. So without further delay, I would like to now present to you Marie Serdynska. I'm just going to share your slides now. There you go, Marie. My apologies.
Thank you. Thank you, Natalie. Today, I'll be talking about, can you flip back, Natalie? Okay, so I'll be talking today about considering cultural safety in working across cultures. Okay, good, this is working. The objectives of the session are to look at definitions and origins of cultural safety with implications for healthcare practice, to look at equalizing power imbalances by acknowledging and inclusively engaging with diverse cultures through the discussion of biases, and to reflect on organizational interaction. I have got to go back. To reflect on organizational interaction with cultural safety and the impact for practitioner empowerment. So at the MUHC, I work with sociocultural consultation and interpretation services. Our mandate is to promote awareness of sociocultural inequities and to collaborate in advancing equitable healthcare delivery through language and cultural interpretation, literature searches, cultural consultation, and training in diversity and racism awareness, as well as equity and social inclusion. And we do have a model for intervention, and that is one of cultural collaboration. It is based on a cultural safety model. So this means committing to ongoing individual and collective awareness of inherent biases and stereotypes, because we all have them, acknowledging the presence of systemic racism and discrimination, and being willing to work through these issues by engaging in difficult conversations to address inequities in all relationships, not always easy, and to arrive at mutually agreed upon goals that respect others' cultural needs and preferences. And this includes negotiation within the wider community. For cultural safety training from an Indigenous perspective, I would recommend Sanyas. They do online training and you can take the courses at your own speed. If you wish to get in contact with them, you can go to their website, or for individual training, you can go through Larisha Lickers, or for organizational training, you can go through Diane Smiley. This is for Eastern Canada. For a definition of cultural safety, it is the ability of the user to define the service they receive based on their cultural needs, norms, and traditions. This requires service providers to look at their own cultural heritages and the historical influences of colonialism that maintain power imbalances and racism. And this is from Paps and Ramsden. I'll come back to those later. Diversity in Canada. 4.9% of the population is Indigenous. 235,000 Canadians experience visible homelessness in a given year. Visible homelessness means they're on the street or in shelters. There are many more people who experience hidden homelessness and are couch surfing or sleeping on friends or relatives' floors. 22.3% of Canadians are people of colour, and together, that population with the Indigenous population make up the BIPOC population, which would be at 27.2%. So that's Black, Indigenous, and people of colour. 21.9% of Canadians were born outside of Canada, most of them immigrants. 13% of the population belongs to an LGBT community and more. Obviously, we have not here mentioned people with disabilities, and that would really take a whole other session. There are many other minority groups. Natalie, I cannot go forward. Oh, okay. There's a glitch there, excuse me. Language is a barrier to service, and there are many languages spoken in Canada. So from the Indigenous perspective, there are many other language speakers. For example, there are 175,082 people who speak Algonquin languages, 96,575 that speak Cree in different provinces, 28,130 that speak Ojibwe. And if we go down the list, we can come to Atikamekw. Joyce Echequan was Atikamekw. Sorry, these slides are jumping. Atikamekw is largely spoken in Quebec. And at the bottom, you have the Inuit languages. 42,065 people speak Inuit languages, almost 30% of them in Quebec and 64.1% in Nunavut. On the other side, you have the immigrant languages in Canada, 7,335,745 people in Canada spoke an immigrant language at home in 2016. That represents 21.1% of the Canadian population. It also suggests that they're more comfortable speaking in their mother tongue, and it represents also a 14.7% increase from the previous census in 2011. There is a disconnect here with the keys. Cultural safety theory and practice. This is a diagram outlining the work, the cultural safety work. You can see in the larger circle, this is a cultural safety zone. The worker and the user are slowly moving into that zone. You have the user's cultural needs, norms, traditions, and historical experiences. The user has been able to express those. The worker is bringing his or her professional knowledge, her knowledge of her cultural heritage, her background, his background, whoever, and their experience or understanding of colonization, and they are looking at their biases. So they are moving into a culturally safe space. There is a bit of a disconnect here in being able to use the keys.
Hi, Marie. We're experiencing some difficulties. I'm taking over the controls, so when you want to flip to the next slide, just let me know. I have the control now.
Okay, yes, next slide, please. Can you move to the next slide?
Cultural safety origins.
Yeah, the one that follows the one that we're looking at. Yeah, it has the three circles in a square.
Cultural safety limitations.
Yes.
Yes, we are there.
It's not up on my screen. Natalie?
Do you see it now?
No. I'm wondering if we should switch back to my version.
I think it's there, may just be hidden. It may be minimized on your end, Marie.
I just have one slide up currently, and that is cultural safety defined by the user. And I cannot get out of that.
So you have remote control again. You should be able to maneuver the slide.
It's not happening.
If you click on the forward.
No, even that image, it's frozen. There are no indications to move forward.
Okay. Sorry, we'll have to try to share your screen from your end. I'm not sure what's happening. So I'm going to stop the share And
Okay.
let's share your copy again. There may be some technical issues with the sound, but we'll have to move through. Thanks.
Thank you. Something's wrong this end. I am not being able to move forward on anything. Okay. Have you allowed a screen share, Natalie?
Yes, you should be able to share your screen.
Okay. So excuse the delay. That's I guess one of the issues with this kind of platform. So we're looking now at cultural safety limitations, and you can see here the worker and the user are slightly further apart now because there is some kind of structural barrier that's preventing them from fully moving forward with the safe cultural care. So you can see they are surrounded by the institution or the organization, they're surrounded by the healthcare system, or it could be the immigration system and the policies and the rules and regulations that come with that. And they're having to negotiate that. So for example, let's say in this case, it's an asylum seeker who is seeking healthcare on the interim federal health plan. And there are some, we've arrived at a place now where there are some medications or treatments that are not covered by the plan, and special steps have to be made to move forward in order to get this extra help. It could be that the organization does not have the infrastructure to process all of the administrative pieces that are required to get this extra help. It could be that the worker is having trouble contacting the IFHP body in order to identify the kind of forms and the steps he needs to take to fill out the applications. So here we're limited by the structural barriers. The origins of cultural safety come from New Zealand. Cultural safety in the Maori language is kawa wakaruruhau. The theory was developed by Ariapati Ramsden, a Maori nurse, and Elaine Paps, and was incorporated into nurses' education in 1996. It was created in response to the inequalities that came from colonization that had negative impact on Maori health in Aotearoa, which is New Zealand. And Ariapati Ramsden, as a Maori obstetrics nurse, observed great injustices. She saw that illness was being diagnosed and treated in Western terms that were not mindful of Maori health belief systems. Today, this is not the case. Maori beliefs and practices are incorporated into teaching and into documentation for healthcare workers in working with Maori patients. There are books that describe the different parts of the body and their significance and the importance of the head, and also highlighting the importance of wanu, which is the family kinship system. there is still work to do. This work is never a fait accompli, but New Zealand is ahead in this kind of work. Cultural safety, however, is transferable to all of the populations I previously mentioned. In terms of immigrant Muslims, there's a study by Cynthia Baker where she looks at the impact of 911 on Muslims. Prior to 911, Muslims were largely invisible, invisible, and had gone about their daily business without too many issues. And suddenly, post 911, people began to take notice of them in negative and stereotyped ways. So Cynthia Baker makes the link with social disadvantage and culturally unsafe health services, meaning that people could go from being relatively safe to being at risk through public perception, which could influence nursing care and obviously is applicable, as we know today, to other aspects of public services for many vulnerable groups. Unsafe health and social care is well documented, or there's a growing body of documentation that looks at this. There was a study that looked at the rates of referral for renal transplant for Black and Caucasian patients. It found that Black patients were routinely not referred for renal transplant because physicians felt it was not compatible with their lifestyle and their culture. There were other factors involved, but bias was one of the key factors in having this happen. When the patients were asked if they would have been interested in this procedure, they overwhelmingly said they would have. There are misunderstandings around parental authority. Racialized families are overrepresented in the youth protection and or child welfare systems. Families arrive in Canada, they are experiencing acculturation adjustments. Their self-esteem is low, they're struggling with finances and discrimination. Their children or adolescents are adapting much faster to the host culture. If there is a parental, an authoritarian parental style of discipline, this can bring them to the attention of the child welfare authorities, and it can have disastrous effects if the workers are not aware or explore the levels of acculturation that the family is going through. There's an underrepresentation of minority groups receiving mental health services. There have been many improvements in recent times. There are more public announcements about mental health. There are some brochures available in other languages, but it's still a giant taboo, and people tend to stay away until it becomes an emergency. So obviously there's some adjustments to be made in the way we approach mental health with different communities. There are incidents of over or under medication. In the UK, Black men who are sectioned for mental health are routinely over-medicated because of perceptions of violence. In other studies, pediatric studies involving Caucasian, I think Indigenous and Black patients, the Caucasian patients are given more or adequate medication versus the Black or Indigenous patients because of possible stereotypes around addiction or their ability to tolerate pain at a higher level. Here we can see the impact of COVID-19 on ethno-racial groups. In times of crisis, groups that have traditionally been struggling come into the forefront. And because we haven't addressed some of the needs earlier, then we cannot meet the current needs fast enough. You can use examples from Hurricane Katrina, where everybody who had cars and resources was able to leave the area, and those who were left behind were low-income racialized communities, and then the emergency services were not able to keep up with the needs. The same with the clean water issue in Atawapiskat, which is ongoing and emerges from time to time. Again, it can never be fully addressed under current conditions. So here you can see on the left the Quebec statistics, and this is looking at the cases of COVID-19 by population racisée des voisinages, and that's by racialized neighborhoods. So where you have high concentration of ethno-cultural, ethno-racial minorities, the percentages of COVID are higher. So just looking quickly at these figures, where there is less than 17.4% of racialized members in a community, the rate of infection is 713 cases per 100,000 persons. Where there are 46.9% of the population is racialized in a community, the number is much higher at 1,145. Remember, these stats are from the first wave, where the numbers are typically a lot lower than the numbers in the second wave. So we should see some changes when we see the research from the second wave. Racialized group versus Caucasians faced greater loss of income, 28 versus 18%. Impact on paying rent was higher at 14% versus 5%, and their employment was endangered. Their perception that their employment was endangered was 49% versus 31%. On the other side of the screen, you see the stats from Public Health Ontario, broken down into quintiles. If we look at the upper quintiles, which are the confirmed cases of COVID by ethnic concentration in neighborhoods, the yellow represents the racialized neighborhoods, and in almost all categories, it is higher than the other quintiles, except perhaps for the travel-related quintile. That is actually a little lower in some case, in one case. So looking at red flags again for culturally unsafe care, populations are underserved or overrepresented in public services. We saw that here through the examples I've given. So populations don't traditionally go for health. They feel they are not getting what they need. And then later on down the line, when the situation becomes more critical, they become overrepresented in health services and others. Other issues are that patients do not acknowledge the problems as defined by mainstream practitioners. For example, this is just an example. A Chinese patient may go into emergency for flu symptoms because he's really or she's not feeling well. In China, he or she would have been able to go to a clinic, being given an injection or a shot, and the problem would clear up quite quickly. Here, they have to wait in emergency, they have to be triaged, there's a long wait, and finally, after a discussion with the physician, they're sent home to rest and drink lots of fluid. Of course, they do not see the problem in the same way, and they have not received the kind of care they were expecting. We'll explore some of these issues more as we go along. And therefore, there's limited follow-through on prescribed treatment or interventions because it was not what the patient was expecting and the discussion didn't happen. Other red flags for culturally unsafe care is that engagement with practitioners remain at a surface level. There's nodding, there's a prescription given, or there's a brief discussion about symptoms, but there's no real connection. There are expressions of distance, distraction, irritation, or anger. I go back to the Chinese patient in the emergency who was hoping to get a fairly immediate solution to his or her issue, and instead is given nothing really but sent home to rest after a long wait. So, but often these things are not really spoken about, so it makes it difficult to really come to common understandings. There are concerns about lack of crossover from dominant culture. So a child with her mother visits the audiologist. The audiologist plays some nursery rhymes, Jack and Jill, Humpty Dumpty. The child does not respond. The audiologist points this out. The mother says, my child is not familiar with those nursery rhymes. And she begins to sing a Caribbean lullaby to which the child responds. So again, a disconnect. So what is the practitioner doing in these situations? They're giving standard information on a handout. There's nothing wrong with that. But routinely, on a routine basis, it's not enough. But they may be neglecting to listen to client and family narratives surrounding the onset of the problems. So when a patient comes or a person comes for help in any kind of service, it's taken them some time to arrive there. They've done a lot of mental processing, going over the problem. Is it really important? Should I really address it? And finally they arrive. And this is the first time for many of them that they are able to tell their story. So they begin to explain that perhaps it was at my brother's wedding that I first felt the pain. And they begin to tell this story, and it's the first time that they hear themselves express their concerns. So if they're interrupted, their narrative is interrupted with pointed questions, then they become confused and they lose track and feel that they're being dismissed. There are other areas where concerns for, let's say, an ultrasound or requests for further investigation are dismissed, where the clinician or the worker, whoever it is, will say, well, no, this is not really important, take this prescription or fill out this form, whatever the case may be. But the person hasn't really received the kind of care they were hoping for. A lot of these interactions are based on unconscious bias. From quality interactions, medical conclusions can reflect on who a person is as well as the symptoms they present. Unconscious bias affects our nonverbal behavior, our level of eye contact, physical distance, facial expressions, which impact on the patient-client's perception of safe care. So when somebody comes, there have been various studies on these elements. Someone who experiences obesity comes for help or comes for a clinic appointment. He or she is very aware of the clinician's expressions and is ready to accept that he or she will not be treated well. If somebody's experiencing homelessness, they only come to a health appointment under great duress because of the lifestyle, they tend to avoid mainstream organizations. So if they do arrive, they're already expecting not to be helped. And the expression sometimes on the clinician or worker from public services face indicates that no, you will not be helped. And so the cycle is perpetuated. These kinds of unconscious bias can result in stereotypes, which are fixed ideas about a person or group and associated behaviors. These kinds of beliefs then lead to racism, racism is prejudice, discrimination, or antagonism against a person or people based on membership in a racial or ethnic group, and they're usually minority or marginalized. The perceptions and behaviors, biased perceptions and behaviors of public service workers can result in patient and client neglect and failure to deliver appropriate care. So what are the roots to cultural safety? Of course, there are many, and we can only touch on some. This is an overview. So beginning to understand the immigration process, the status of asylum seekers, of refugees, of permanent resident status, and so on, and understanding what people in those groups are entitled to, what they may have come from, what they have lived through in their countries of origin or other countries, understanding the indigenous realities, the historical oppression through the residential school system, the lack of adequate infrastructure existing currently in communities that impact on health, and of course, cultural beliefs and practices. And for the LGBT plus community who are more present in mainstream society, health needs are still not adequately addressed. There is a lack of training on this topic. Healthcare workers or other service workers are often uncomfortable in knowing how to use language when addressing LGBT members. And of course, this makes it uncomfortable for patients or clients who then don't always get what they need and experience inequities. Another factor is to address power imbalances and biases using a collaborative approach to care. So asking the person how you can help them, what do they think they need, and then being able to explain to them what actually is available and working through. So understanding the stresses from of the different communities are key factors. And recognizing and reducing barriers to service, understanding the importance of language, asking people which language they're more comfortable speaking. You may have to ask that question in more than one way. Most people will say, yes, I'm fine in English or French, because they want to be served. And if they say that they speak another language, or they're more proficient in another language, they fear they won't be seen. So these are all key factors. Looking at transportation, how far did the person travel for care? Did rentals, housing rentals, apartments are much more expensive now, so people are having to move further away from the urban hub. Looking at experiences of discrimination and housing issues. How many people are living in the house? What is the relationship? And you may find that there are some issues there which would have relevance for health. Make special efforts to overcome biases, question your biases. We all have them, and they arrive regularly, and we have to say, well, what am I thinking? Let me put that to one side and find out more about this person in front of me. Make special efforts to overcome patients' and families' reluctance to engage that may originate in historical oppression. So if somebody's not engaging and you've seen them more than once, and you're just really giving basic care and they're responding in a very minimal basic way, then you really need to find out what's going on and to ask them, well, you know, you're not saying very much. I'm wondering if what I'm telling you is useful to you. If it isn't, then please tell me and we can find another way to proceed. So really taking the time to help a person engage, discuss their experiences of discrimination. So if someone came to emergency and someone was rude to them and they waited several hours, try not to say, oh yes, that's emergency, they're short-staffed, there's a backlog. All of these comments are true, but they dismiss the person's experience. So take the time to listen. Here we can see the impact of cultural safety on the worker-client interaction. On the side of the worker, you have the culture of the profession and their code of ethics. You have the institutional culture, which sometimes is in conflict with the culture of the profession. You have the workers' background cultures, the cultures that they come from. You have their level of job security, whether they're permanent, part-time, or temporary. And you have the Canadian provincial context. On the other side, you have the family or patient. You have their cultural practices. You have the countries and the cultures they pass through and the historical origin. So more and more, many people have lived in more than one country before they arrive in Canada. Some of them have been in refugee camps. Some of them have undergone political conflict where there has been violence. They have not felt free to speak. That all impacts on the encounter. And then you have the family cultures. More and more people are bicultural or tricultural. They have more than one culture in their family. And so these influences the way they proceed in terms of their values and their health and other factors. Their level of immigration status, whether they're an asylum seeker, refugee, or have permanent residency, will affect their level of security. And the period of cultural transition. So if they are relatively new, they could be wearing traditional dress. They could be traveling far across town to buy ethnic foods, which are costly. They may have language issues. And all of these are present in the encounter without being spoken about. If it is a young person who has sought asylum because they are a member of the LGBT community and their life has been threatened in their country of origin, and their general cultural milieu doesn't look on their sexual orientation favorably, that again will affect how they present in an encounter. And again, many of these aspects are silenced, but all influence the way we work. To engage in culturally safe practices, need inclusive organizational and team policies, openness to others, willingness to engage. With a collaborative approach, patients, sorry, I have to go back. Patients can fully engage with workers and be prepared to discuss health beliefs for improved health outcomes. Here quickly we'll look at the role of the healthcare interpreter, who is key in bridging gap between language and culture. This model's adapted from Cindy Rowe. I've designed it as a funnel. The outer rim of the funnel is the interpreter's key role as a channel for communication. The inner tube of the funnel is his or her role as a clarifier, clarifying missing information, terms not understood, be they cultural or medical. And then as the dialogue intensifies, the role of the interpreter as a cultural mediator, where perhaps there's a barrier to moving forward with care, treatment, or accessing services, what's going on in terms of lifestyle and culture, what's happening in terms of the medical aspect or the care that's being offered. Is something not being understood? Is something incompatible? This is where the interpreter can help bridge the gap by having each side ask key questions. And last is the role of the advocate, where people may not have food at home but are reluctant to discuss that. The interpreter can bring that to the attention of the worker. If the family is in a consanguineous marriage, which obviously is not something that takes place here in Canada, but does in many other cultures, they may feel they cannot mention it because they'll be ostracized. The interpreter can help them bring that to the table, especially in terms of genetic counseling. And off to the side is the satellite community link. So when newcomers meet an interpreter for the first time, they're very grateful that someone who speaks their language they can relate to, and they have many needs and questions. So the interpreter can help by putting them in touch with newcomer groups where they can have access to resources and meet others in similar situations. And this is the collaborative work between the interpreter, the provider, and the patient. It's a triad or a triangle. So if the room is suitable for the setup, you would have the patient and family on one side with their needs and their practices, the interpreter on the other side acting in their role as a channel, And then so they would be at the wider base of the, it's a sort of upside down triangle, and at the narrow end of the interventions and evaluations. And there would be adjustments for the culture and social determinants of health. So that all has to be part of the discussion. If you're in a narrow examining room, I think the examining rooms generally are wider now, well then you just have to make sure, and you cannot be seated, that you place yourself so there are no power imbalances, so that you're not talking over people's heads, that the worker is always addressing the patient or family, and that they are always addressing the worker, and the interprets. So there is a better bridge built when the communication is directly from a client, patient to worker. It's useful to have pre and post meetings with interpreters, especially if critical information is being delivered, just to acknowledge that, so the interpreter is mentally prepared and better equipped to handle the reaction. It also indicates that the worker will be better able to handle the reaction too. Use teach back to ensure understanding and assess literacy. Sometimes there are delays in communication. Some people are more reflective. Their cultural communication styles are more reflective. They tend to wait. They want to discuss things with family members back home. They want to review the information, so they may not say much. So you need to understand that. Other people may have communication issues. They may have speech impediments. There could be many things that are preventing a full open dialogue. You need to know that. If you use teach back and ask the client or patient to please repeat back to me what I have said, so I can be sure that I have given you the accurate information, this is a way of assessing what was understood while you're taking responsibility for it. Ask about the social situation to ensure equitable recovery, which obviously includes transport, living arrangements, and income. And for future practices, engage in your cultural and racism awareness work. I'm sure many of you are already doing that. Please continue. There is a growing body of literature out there. If people need some follow-up material, I'll be glad to put a list of reading together. Seek out alternate perspectives in decision-making. So generally, we tend to go to the same people when we consult around issues, because we know them and it's easier. But make a point sometimes to get different perspectives, and increase collaboration with diverse patients, clients, and colleagues. The more we engage, the more we understand. And where there are systemic issues and structural issues, align with advocacy groups or with other workers who are seeing the same barriers to services for their clients, so that you can document the matter and bring about some change. Thank you. I think Natalie is going to deliver the polls now.
Yes, thanks, Marie. I just launched the poll. Everyone should be able to see the first question. Are you able to see the question, Marie?
Yes, I can. It says host and panelists can't vote. Oh, you want me to okay. Can everybody, I assume everyone else can see the question.
Yes, I see the results are coming in now. So we'll give the participants maybe 15, 20 more seconds, and then I'll end the polling, and then you can discuss the results if you'd like. Just a few more seconds. There's still some results coming in. Okay, thanks everyone. I'm going to end the polling now. Let's see the results.
There's a second question.
Yes, do you want to look at the first question's results first though?
Okay, yeah, sure. Okay, so yeah, there's mixed results. So yeah, okay, yeah. So some more explanations I think are required for future training. Okay, we could go to the next question.
Okay. And I've launched the second question. And I'll give a couple more seconds. Some results are still coming in. And I'll end the polling now. And here are the results.
So the actually I didn't clarify the answers for the other questions, so we'll go back to that in a moment. So yeah, so 61% highlighted understanding immigration, Indigenous, LGBT, and other minority stresses. Special efforts to overcome biases, 32%, and nobody answered on handing out a routine prescription or response, which is correct. And special efforts to overcome families' reluctance to engage. There were less people who indicated that, but largely the answers are correct there. Could we just go back to the last question?
I'm afraid once I've closed the poll, the results are gone. So
okay,
yeah.
Okay. So the result, the first question is yeah, the results were a bit mixed. Anyhow, to be looked at.
Great. So I'm just looking at our time, Marie. We have approximately 5 minutes left, but I realize due to the technical difficulties, we'll be going over a little bit today. So for those of you who are listening and you have to leave the session promptly at 2 p.m. Eastern time, just a reminder that we are recording the session. It will be available on demand. So we'll continue and we'll likely go over by about 10 minutes this afternoon. But I do see that there's some questions for you, Marie.
Yes.
And Mariah has been in the background fielding them for us. And
so you want me to answer from the screen? Yes.
No, I'll ask them to you directly.
Okay.
I'm just going to field them for you. So our first question, Christine would like to know, do you have any tips for how you have addressed bias in colleagues who you may have observed?
Oh yeah, that's a huge question. I think there are many different ways, and it depends on your ability to respond quickly. There's no easy answer, but you might ask them, why do you think that? What gives you that impression? And start to explore it with them, and then bring some alternative facts to their attention. Alicia Flanagan, where can we find reliable and trustworthy information on various cultures, countries to educate ourselves? I want to better understand and continue to grow my cultural awareness and keep a culturally safe environment? Okay, that's also another huge question. There's a lot of information available on the internet. There's a lot of free access to documentation and articles. If actually, I might be able to help you with that if you contact me outside this session, and we could maybe pinpoint what you might be looking for so that I can give you something more focused, an answer that's more focused. From Sita, thank you for this informative presentation. Given the global civil rights movement ignited by death of George Floyd and public outcry of Joyce Echaquan, what are the first steps that we can take as individuals and as organizations in practicing culturally safe and sensitive care, I imagine? I think we have to look at our biases. We have to do our cultural and racism awareness work. At the MUHC in the winter, we will be looking at unpacking racism. We'll be offering, I think, approximately 5 sessions to look at how we inherit our values and belief systems, and to go from there. We have institutions based on majority white societies. So obviously this is going to take quite a while to unwind, but beginning to initiate some of these discussions in your workplaces. What is the difference between cultural safety versus competency? Yes, Christine, you had asked me this before. I didn't mention it at the beginning, but I will now. So there is a power imbalance inherent in the term cultural competence, and who can be competent in someone else's culture, given all the different scenarios I've described. So cultural safety is a better way to proceed in ensuring safe spaces for people to speak. Are there mandatory courses for healthcare professionals regarding diversity and understanding multicultural differences? Simulated station exams. Are there free courses as a refresher for social workers, or at least a specialty course required for ones working with immigrants? Again, there are many answers to this. There are intercultural courses available at the university level and in different places. There is Sanyas for Indigenous cultural safety, and there are courses offered for working with immigrants. So all of the above. Perhaps we can be in touch after, and I can maybe direct you specifically in your area. Terry Morrow, are there assessment tools that you can recommend on organizational implementation of cultural safety training? I would have to look into that. You can develop your own tools in conjunction with community groups or community representation, but there's some literature out there, again, to follow up. Where are we? As a system, how can we uproot biases? Yeah, this is a long, this is not something we can achieve by Christmas or the holidays, the December holidays. But this is ongoing work. And again, having these kinds of discussions in our workplaces, having people come in, engage in cultural exchanges and exercises, we start to see how entrenched some of our belief systems are. Ongoing work.
That's great, Marie. And I think Zabi's last question was just to clarify his previous question. So thank you. And thank you for your offer to be in touch with the participants. So if anyone does have any further questions for Marie, you can contact me directly, and then I can field the questions, forward them to Marie's email. So thank you very much for your offer, Marie. That's great.
Thank you.
And thank you so much for today's very informative presentation. Thank you everyone for joining us today. Our apologies again for the technical issues. Sometimes a Zoom webinar can misbehave, so thank you for your patience. And we do welcome everyone to join us for upcoming events. We have one more session before the holidays on December 16th, and then we kick it off in the new year with 2 sessions in January. So hopefully everyone can join us for those sessions. And of course, you can go to our website to register. And following today's session, you'll be invited to complete a survey to share your feedback with N4. And again, if you missed any part of today's presentation or you would like to watch this session again, we'll post this information to our website, the on-demand version, within 24 to 48 hours. And thank you again, Marie, so much for your time today. We really appreciate it. And thank you again, everyone. And we'll see you again in the future at another event. And in the meantime, stay well and stay safe.